Hi, I'm Eddie Patton, a practicing neurologist in the Houston area, and I currently serve on the board of the Texas Neurological Society. I am excited to bring you this edition of The Business of Neurology. This video series is sponsored by the Texas Neurological Society. The goal of this series is to help members of TNS understand certain business aspects of the practice of neurology. We are currently in the midst of an unprecedented public health crisis caused by COVID-19 or coronavirus. This pandemic is going to have long economic effects on our economy and healthcare system. As we try to practice social distancing, we have to figure out how to take care of our patients while trying to minimize clinic traffic as much as possible. One option is telemedicine. The telemedicine industry has been fast-forwarded several years due to this pandemic. But this is the physician scrambling to try to figure out this emerging technology and how to incorporate it into their clinic. Well, we have an expert here today that's going to help us figure it all out. That expert is Dr. Eric Anderson. Dr. Anderson is a neurologist and telemedicine specialist. He is an innovative physician scientist that has been recognized as a national leader in telemedicine and mobile health. Eric is a true early adopter to telemedicine and is one of the pioneers of the telestroke industry. He speaks nationally on the topics of telemedicine, mobile health, and medical economics. His current practice includes telemedicine in over 32 states in over 240 hospitals and as the director of telemedicine for Corticare, a national telemetry company based in Carlsbad, California. He serves as the Department of Neurology chair, having previously held roles as vice chair of quality as well as subject matter expert on the tele-EEG for SOC Telemed, which is one of the largest telemedicine companies in the nation. He also devotes his time to operating his personal intensive neuromonitoring company. This company is a tele-EEG company in Florida that specifically caters to private practices and small hospitals in the southeastern region. Eric leads several efforts in bringing telemedicine and technology to the forefront of medicine by serving on the Medical Economics and Practice Committee and the Conference Subcommittee for the American Academy of Neurology. Other roles include being the past chairperson of the Telemedicine Work Group, the past vice chair of the Practice Committee, as well as the past member of the Practice Management and Technology Subcommittee and the Meeting Management Committee for the American Academy of Neurology. I am looking forward to talking to Eric about this emerging industry and how we can use telemedicine to continue to provide the valuable neurological care to our patients that they need. All right, well, Eric, first of all, I want to thank you for taking time out to talk with us today about telemedicine. I'm very, very excited about this interview. We are in the middle of a public health emergency due to COVID-19. This is changing how we are actually practicing medicine with this social distancing. And as you know, everyone from the President of the United States to state governors have all issued or changed policies dealing with telemedicine. But what this has done is caused a scramble where neurologists and physicians are really trying to figure out how to integrate this new technology into their clinic and really figure out telemedicine as a whole. Interestingly enough, you were an early adapter, an early adopter to telemedicine. So why don't you start off by just telling us a little bit more about how you got involved in telemedicine and what were the things that really pushed you to get into this field?
Sure. Well, first of all, thanks for having me. Always happy to share. But, what got me initially into telemedicine was back when I was a medical student. I was fascinated with a lot of the early telestroke papers that came out of the REACH group at the College of Georgia. And I kept up with that literature and followed it very closely. And by the time I was a resident, I spent a period on night float writing an IRB to use a mobile device, the iPhone 4, before it had been released, to evaluate stroke patients. Now, the reason that was important was because, the idea of being able to bring a neurologist to the bedside and be able to see that patient instantly, especially in places where there weren't neurologists, was just really compelling to me. The problem was that at that time, and this isn't the case anymore, but at that time, telemedicine cards cost around $50,000 or more. And, it was typically not affordable for places that needed it, rural areas and other hospitals that didn't have neurology services. So when I put together this study at Grady Hospital and showed how we could evaluate patients remotely just using a simple everyday off-the-shelf item, that kind of got a lot of press. And the idea of mobile health using smartphones, ubiquitous technology to replace these expensive machines was really grabbing. And so, needless to say, that publication generated a lot of press and opened a lot of doors for me and kind of solidified my career path. I realized, okay, I'm on the right path to doing what I want to do. And so by the time I was a fellow, I was a fellow in epilepsy. I started a small tele-EEG company as a fellow in Georgia, and decided to kind of strike it out on my own and acquire clients. And larger companies saw what I was doing and hired me to do the same thing for them. So I built out the national EEG network for some other companies, and the rest is kind of history. So now, as the chair for neurology at SOC Telemed and the medical director for Corticare, and still running my own private practice, I oversee about 70 neurologists, and collectively we see a volume of about 7,000 to 8,000 consults a month across the nation.
Wow.
And I've worked extensively with the AAN in regards to their telemedicine efforts for the past 6 or 7 years. So, I'm pretty ensconced. There's no shortage of work, and this is pretty much where I am.
Wow. That's awesome. And I'm so glad you're speaking with us about this timely topic. So that's awesome. So tell me a little bit more about if I'm new to telemedicine and now with everything that's going on, of course, some people by necessity are starting to do it. But high level, what are some key features that neurologists, physicians need to know before they embark upon this?
Well, I would say number one is that back in the day, it was relatively unapproachable because the technology was so expensive. The IT, the logistics, everything cost a lot of money. These days, that's not the case. There's a lot of different vendors for software solutions that people can use over everyday home equipment. And so I would say that the technological barrier should be considered easily overcome at this point. Other things that I think new people starting off practicing telemedicine should understand is that the practice of medicine always occurs where the patient is, right? So you have to be licensed in the state that your patient is in. It doesn't matter where you are, but you should be licensed there, you should be credentialed there, and most importantly, something that a lot of people forget is that your medical malpractice should also cover you in these states. You need to let them know that you're doing this before you do it, because you would be surprised with a lot of medical malpractice carriers who don't provide widespread coverage. So that's an important thing to double check before you start doing that. Another point that I would bring up is that we are held to the same standard as an inpatient visit. So you need to make absolutely sure and document any limitations that you may have or encounter. You should never be cavalier and guess if you can't see. Yeah. If you need to evaluate something and you can't, you just need to say that you're unable to and document that. And make sure that if this is a key feature of your exam or a decision point, that you refer the patient to someone in person who can make that determination. I think those are the things that I see time and time again that people forget. And so I would say that from a very high level, those three things are the most important that I would put out there.
Yeah, and you touched upon that liability issue, and we certainly will dive into that a little bit more a little bit later as well. But right now, let's get to the heart of the matter. What everyone wants to know about is this confusion and over what exactly is a telemedicine visit. What's the difference between a virtual check-in versus an actual visit? And I understand that now with the regulations being loosened, there's overlap between the regular visits, or you can bill for regular visits. So if you could give us the landscape of the different visit types, even before the coronavirus outbreak versus what we have now.
Yeah, no, absolutely. And I think some of this requires just a little bit of history.
Mm-hmm.
And so the first thing to understand is that, a lot of when they were first trying to figure out how they were going to bill for these services, they pretty much used existing codes and then put modifiers or flags on the end of them to say, okay, this was done over telehealth. This is an inpatient visit, but it was done over telehealth. And so that's where these prior modifiers, 95 and GT, kind of come from. And so, from history, that's kind of where that came out. And then, as we've moved forward, there have been some G codes and other codes that were specifically designated to remote services, and we'll get into all of those. But one of the modifiers that kind of hung around was that if you're using a CPT code for an inpatient evaluation, but you're doing it remotely, you just add the GT modifier on it, and that's something that has kind of stuck through it. Okay. Now, with the advent of COVID, something that's important to know is that CMS has put out statements basically saying that they're not going to require anyone to put additional modifiers on it because they don't want it to be confusing, and they basically opened up a wide swath of in-person CPT codes and approved them for telemedicine. And there's some links to CMS articles that we can provide as supplemental material to this interview. Mm-hmm. But I'll share some slides here, and we can go on to look at some of these codes. We'll start with here we go. We'll start with the telehealth visits here. Can you see this?
Yes.
Okay, perfect. So the first thing to understand about telehealth visits is and this is coming from CMS. All right. So CMS sets the stage. So when we look at these, we should consider that this is applicable to Medicare patients. All right. Okay. So for Medicare patients, and then from Medicare, other payers tend to follow suit. And the great thing about Texas is that Texas, as a state which mandates parity payments between what can be done in person and what can be done over telemedicine, they also require all of the insurance carriers in Texas to post all of their telehealth and telemedicine rules on their websites. Okay. So if there's any variation from what CMS does, you should be able to find that for your particular payer. Okay. So that being said, telehealth visits by CMS are defined as real-time synchronous audiovisual visits, meaning that you can see the patient, they can see you. You can hear the patient, they can hear you. It's like what we're doing now. It's this virtual conference. Mm-hmm. And so from that, they have specific CPT codes that can be used, which are just like the CPT codes you use when you're seeing someone in the office. They're based on complexity. It's the same thing as an in-person visit. So there shouldn't be any real change in the way you're thinking about it. Mm-hmm. So this applies to our new outpatient codes, 99201 to 99205. Our established outpatient codes, which are 99211 and 99215. And then recently, as of a CMS publication on March 30th, 2020, they've also included ED visits, 99281 to 99285. Okay, so Those are all prior CPT codes that were in-person codes, which previously you could attach a GT modifier and designate it as being telemedicine. And these are codes that you can use now for telehealth visits. I've included some G codes. These were established recently in the past couple years as specifically telemedicine codes, and these are time-based. And this is G codes G0425 to 427 and G0406 to G0408. And these are all ED or new inpatient or follow-up inpatient codes, and they're based on time. Okay. So when you're seeing people, you can use these. And I would say before March 30th, if someone was seeing someone inpatient, I would have recommended the G codes. But as of March 30th, now that they're allowing these complexity codes in the emergency department, if you're seeing someone in the emergency department, you could choose to employ those as well. Okay. Does that make sense? Is that clear for the telehealth or televisit codes? This is the one-on-one over video, seeing a patient, examining a patient codes. The other codes that we're going to talk about, the e-visits, telephone codes, virtual check-ins, all of that kind of interprofessional codes, all of those do not necessarily require this audio-visual communication.
Yes.
Does that make sense?
And so these are visits that we schedule as provider are initiated by us as opposed to initiated by the patients, which are more the virtual check-in virtual visits that I think we're talking about later, correct?
Right. So these are to replace your clinic visits. So if
Exactly.
you're seeing a
Yeah.
patient for the first time, which you can now do,
Hmm.
since CMS is waiving the requirement for an established relationship with a patient, you can then start seeing them new over outpatient video. You can see them over video for your established follow-ups, things like that. The virtual check-ins and the other things kind of happen in between those visits.
Yeah, and I think that's very important for our viewers to understand because I remember specifically when we were advocating to get increased legislation for telemedicine, that question always came up as far as can you use telemedicine to establish a relationship?
Mm-hmm.
And prior to this, there were some issues with that, but it's important to note that now you can.
Yes, I believe it was in Texas, Senate Bill 1107, if I remember
Hmm.
correctly. That was the case that was brought against, I believe, Teladoc
Yep.
on whether or not that needed to be established. And so, yeah,
Yep.
that had changed at least within your state, and so that's an important point to make as well. But from a CMS standpoint and from a billing standpoint,
Hmm.
this is what is required. Now, there's an important distinction to make here as well.
Hmm.
So CMS is a federal agency, and just because they say you can get paid for doing certain things doesn't mean that every state allows it. So you
Okay.
have to make sure that you're consistent with what your state requires as well. And a lot of them have afforded leniency in this regard.
Hmm.
So, but it
Okay.
should be taken on a state by state basis.
Excellent. Thank you.
Okay,
All right.
and so let's move on to the next code set that we're going to talk about. So we'll talk about e-visits. So e-visits, CMS had pretty much defined as visits with established patients through online portals, through
Okay.
your electronic health record, right? So the typical example of this would be someone's using Epic or another electronic health record, and then you have a patient portal, and they're sending you questions. They're sending you questions. They're asking you, what should I do? What should I do with this? And you're billing to respond to these requests, right? And your response to these requests can be done. They can be done over, a text session. They can be done through a different type of communication or audio visual. But that's typically how these are, and they're based on the amount of time that you spend doing that. So that's these codes here.
Okay.
The one thing that's important is that the patient does need to verbally consent to receive these services. You can't just provide them and then bill them. So usually as part of an enrollment to use the portal, this is part of the standard paperwork to agree to these types of services.
Okay. And when you're coding one of the e-visits, the time requirements there, is it important to differentiate between like the amount of time, let's say you're reviewing a lot of records beforehand before you respond, do you incorporate that into that time or is it just face-to-face time?
Yep, by definition, the time you spend reviewing records, looking at labs, following up on imaging is all part of this time.
Excellent. Thanks for clarifying that. Sure.
Not a problem. Is that clear on that one?
Mm-hmm.
Perfect. So we'll move on to virtual check-ins. So virtual check-ins is, this is typically initiated by the patient as well. This also requires a patient's verbal consent to provide these services. You can't just bill them without them consenting to do this. It's typically for established patients unrelated to a medical visit in the past 7 days and does not lead to a visit in the next 24 hours.
Okay.
So a good example would be, I went up on my medication. I'm having problems with it. What should I do? Right.
Mhm.
And then you would respond to this. This is outside of a portal. You can have this, maybe they called into your office and you've got to call them back. They've texted you. You have some other form of communication. And you can also do audiovisual communication back to them. You can schedule a Skype meeting and talk to them about it. Make sure that you clarify everything. Just a couple codes for this: G2012, telephone, email, text, or audiovisual, and then G2010, which is store and forward. Now, when I'm talking about store and forward, this is a separate code. For example, if a patient sends you a video, like here's what's going on, here's my tremor, here's my kid having a seizure, here's something else, here's a picture of whatever, and then you can get back to them on that. But it's a different code when they're sending you what we call store and forward services. Does that make sense?
Yeah, absolutely. And I wish I
Great.
had this information before, because this is, a lot of these things we've been doing without without billing. But it's good to know these codes are available. And I have heard from a number of neurologists that was part of the confusion, was between the virtual check-ins versus some of the other codes as well.
Yeah.
So that helps to clarify that. Absolutely.
Not a problem. So we'll move right along to the interprofessional consultations. So this is typically physician to physician or physician to provider. I'll give you a great example of this. A great example would be someone from the hospital calls and you're taking care of a patient inpatient, and they say, we found this person has a PE, but they also have a brain bleed. Should we start an anticoagulant on them?
Okay.
You go and review the chart and you call them back. You never actually see the patient or interact with the patient in any way, but you can still bill for that interprofessional communication, right? This can work on the outpatient basis as well. If someone has a quick question on a patient's medication when they're seeing them, like a primary care provider or something else, you can bill for that interprofessional communication. That again is based on time, which includes your chart review, reviewing images, and looking at labs, etc.
Okay.
Does that make sense, how we use that?
Absolutely. So if a referring physician has a question about a neurological case, they can basically send you records or send you that patient's information to do a chart review, and the amount of time you use, that's where you would use these codes for.
Typically, yes.
Okay.
Correct.
All right.
Yeah. All right. And then lastly are the telephone consultations. Now, there was a time where these were not billed, right? They were not reimbursable, but that's changed. And so it hasn't just changed under COVID. This is something that had changed recently in the past couple of years, because there's a lot of statements out there, if you look online, saying that these are not reimbursable, but that's dated information. These are reimbursable, and these are things that we can use. Again, not requiring any modifier because they are just telephone. The stipulations regarding these are that they cannot be billed if the visit's in the last 7 days or leads to a visit in the next 24 hours, similar to the virtual check-ins.
Okay. And so explain the difference between the telephone consultation and the previous visit. With this is just if a provider calls you personally without reviewing any records, or explain the difference between the two.
Yep. This can just be a patient calling in and saying, I just need to get some extra medication, or my medication needs to be changed, or I went up on the dose and I just need to come down, or, I've got this rash, what should I do? And you can just call them back really quick and, do something like this. These typically, I don't believe they reimburse fantastically, so they're typically for very short kind of telephone conversations with patients. But it's still something you can get paid for, right? It doesn't require, further communication or other type of workup. It's just quick little, I spent so much time. But of course, the cutoff is 5 minutes, so it's got to be at least 5 minutes. But certainly, I would say that you're hard pressed to spend any time after you look up a patient, kind of look at their records, know who you're talking about, and call them back to spend less than 5 minutes. So
absolutely,
say you're pretty safe in that.
Well, that's great. That really helped to clarify a lot when it comes to those questions, as far as am I coding appropriately and which codes to use.
And I believe there was also the other thing that I have are just to kind of go over the modifiers.
Yeah, absolutely.
Just to make sure that we're all on the same page here, because that can be confusing. I think the best way to think about modifiers in the world of telemedicine is that they're typically used as flags or markers so that they know what this is associated with, so we can look at the information later.
Okay.
All right. So GQ has been around for a long time, and that's associated with only an Alaska or Hawaii federal telemedicine demonstration project. It has nothing to do with any other state or any other service outside of that. So GQ is only that. Okay, nothing else. GT is the one that had typically been adopted. And just to clarify, these three that I'm saying are in effect on this slide, these are three that CMS still wants flagged. All right, for these particular uses. Otherwise, since they've been flexible with everything else, they've eliminated the need for a modifier when using these over telehealth. And we'll again include that CMS communication as a supplemental to this interview. So GT is typically used for critical access hospitals, method 2 billing. That's another one. And then G0 for acute stroke. That's specifically related to the FAST Act that we helped pass. So GQ, GT, G0 are the only modifiers that CMS is requiring during the COVID outbreak, or at least that's what the CMS communication says. Now, GT is something that had been used prior to the COVID outbreak, specifically relating to CPT codes that would otherwise be done in person. So you use that CPT code to see someone in person, and then you use that same CPT code with a GT modifier to indicate that it was done over telehealth services.
Okay.
Does that make sense?
Yeah.
So that's something that likely will occur again after COVID is over. According to the CMS waiver, they say it's not necessary to code that. I don't think it hurts to continue to code GT modifiers for those CPT codes. So my recommendation would be to continue to do it.
Okay.
But as far as the rest of them, you probably don't need them unless you're doing those specific things. Unless you're in Alaska or Hawaii, you're a critical access hospital using method 2 billing, or you're, performing acute stroke care. So as far as the modifiers are concerned, I would only attach a GT to a CPT code for a regular, what would otherwise be an in-person visit.
Okay. And the 95, that's the same thing
The
as GT?
95 is an older code. I believe that there are still some private payers that are using it. So I would check with your private payers. This is specifically for CMS. And like I said, most private payers are following CMS's example. But if there's any question, I would check with your private payers. And like I said, one of the benefits of being in Texas is that Texas requires all of their insurers to put all of their telehealth requirements on their website. So you should be able to find that for your specific private payer.
Okay. Thank you.
I believe United Healthcare required the 95 at one point. So I would just double check for the private payers. But for CMS, you wouldn't need it.
Okay. Well, thank you so much for that overview of the coding system, and I really think that's going to help our listeners to really to clarify and help billing departments as well. So now that we know the codes and we know the landscape of what we can do, what's most important as far as your documentation and your note? You talked about documenting that you've gotten consent, but are there any other hot points that you can give to our listeners regarding documentation?
Yeah, so as far as documentation, there's a couple things that we tend to put into all of our telemedicine visits, and that is one, stating kind of a general disclaimer stating that services were provided over real-time audio-visual communications to meet the requirements that CMS and other insurers would pose. So just kind of state that. Other things are to make sure that you've documented that you have the right patient. So name and date of birth is always an important thing. I spoke with the family or the patient and confirmed that the patient's name and date of birth are, as shown in the chart. That the services were provided over telehealth services, real-time audio-visual. And then I also put in that I discussed with the patient that, and this is from more of a medical legal standpoint, I discussed with the patient that the services provided over telemedicine can be limited and not all questions can be answered. So I think that's an important part to put in as well. But otherwise, I would say that, you would document at least the telehealth visits or the E&M codes exactly as you would document in person. Okay.
And the time designation that you have to document, again, starts when you first open a chart and start reviewing the chart, not necessarily just when they,
That's how we do it. Correct.
And speaking about the documentation and insurers, I know that sometimes private insurers or private payers don't necessarily want to pay. Is there an appeals process if you file some of these claims for a telehealth visit, and form letters or any other advice you can give with getting those claims paid?
Yeah, absolutely. So luckily it appears that several of the private payers are paying. One of the great things about Texas, again, as I said, it requires all of your insurance payers to place on their website how they treat telemedicine. And I know that in looking at some of the Texas ones, I know that Aetna, amongst others, have followed Medicare's example in relation to telemedicine payments, and that information is listed on their website. Some of them are even completely eliminating the copays. But that's, again, at the physician's discretion to eliminate the copays for telemedicine visits. but I would advise everyone to check with private payers for specifics regarding billing telemedicine services. And if there's any difficulty in getting paid for services, please know that the American Academy of Neurology is being very aggressive in following up with the payers. Of course, during this national emergency, the insurers are swamped with calls and there is a delay. That's something that a lot of people are reporting and we're running into. But if you're denied payments for telemedicine services for any reason, you have another resource, and that's to reach out to our email address at practice@aan.com and list your issue in the insurer, and our coding and payment policy folks will be in touch. We've been watching that very closely. There's a group of us who have put together all of the telemedicine and payment information on the AN website, and that's constantly changing as these reports come out. So we're in that with you, and we are contacting payers.
Can you give that website again, and we'll also provide a link?
Sure, I'll put the website for the American Academy of Neurology COVID resources as a supplemental at the end of this. But the email address again, and we'll put that in as well, is practice@aan.com.
Excellent. And we all know that not seeing a person, not seeing your patient face to face, can open you up to some liability, not being able to touch them, or examine them. Right now, we're converting to telemedicine out of necessity based on what's going on with the COVID outbreak. But looking forward, those who want to continue in telemedicine, can you touch base on just what are some of the liability issues to look out for when it comes to a telemedicine program?
Yeah, absolutely. So, and I get asked this question a lot. So a lot of the theoretical liability is different depending on whether or not there's a physician in between you and the patient. I think that's one way of looking at it, one of the simplistic ways of looking at it. For example, when you're seeing a patient in a clinic or in a hospital, there's an ED physician or there's a clinic physician or there's someone else who's in between you and the patient. So they're pretty much consulting you on a specific neurologic issue. So you're going to be held to the standard of seeing that neurologic issue. Legal liability is theoretically different if there isn't that physician or other provider in between you and the patient. So for example, if you're seeing someone in their own home, and they fall because of something that you're doing, or you miss that weak leg is actually a broken leg or something like that, your legal liability is theoretically higher. And so, and that theoretically leaves you a little bit more responsible. So ultimately, you should be more thorough if you're seeing someone without another physician present. And then also, if this is a patient that you're familiar with, that you've seen in clinic, you've examined before, and you're just doing follow-up, certainly your confidence would be greater than if you're seeing someone for the very first time over telemedicine.
Okay.
Additionally, I think the other thing that I would mention is that you need to understand that telemedicine is limited. It's a limited way to see patients. It is not a substitute for in-person care. And so what we have to understand is that there are things that we can and cannot do over telemedicine currently. So the short list of those includes vestibular conditions. There's no way to provide provoking maneuvers on a patient and follow their eyes and try to figure out whether or not there is a central or peripheral cause. That's not something that we can do right now. It's a technological limitation. But I've had some neurologists guess on that, and that's not a good idea, because ultimately you're going to guess wrong. Another issue is ophthalmology issues. So not being able to do a fundoscopic exam unless the patient is lucky enough to have their own fundoscopic camera is also something that's probably going to be off limits. And being able to do formal visual fields or other things are also limited. So not being able to do a comprehensive eye exam is another limitation of telemedicine. And then when we talk about neuromuscular conditions, when we think about tone, reflexes, muscle tension, cogwheeling, all of these types of more subtle findings that require you to touch a patient, these are things that we typically advise against doing. Like I said, if you have an existing neuromuscular patient that you're following up, your confidence level is going to be very different than someone you've never seen before, and you just have to understand that and put your recommendations around that reality. And then lastly, for people who do inpatient services, doing brain death examinations over telemedicine is very high risk and is not something that we typically recommend people do. I understand that there are academic research projects going on trying to see whether or not they can do that over telemedicine, and that's great. I think it's great that people explore these issues, but for the general practitioner, I would advise against doing that because of the medical legal risk associated with it.
And I will bring up, I remember a couple of months ago reading, there was a article that came out in the journal, the Green Neurology Journal, regarding the telemedicine work group that looked at different types of neurology and which would be best. So certainly our viewers can could reference that as well.
Absolutely.
So talking a little bit more about privacy with the with the current regulation changes regarding the COVID-19 pandemic. They've loosened up a lot of the privacy laws concerning what can you use to establish this audio-visual relationship. You can now use FaceTime and Zoom and a lot of other things that you weren't used before. In your opinion, do you think that this leniency regarding the privacy laws will continue after the COVID disaster classification is over? And what are some of the importance of using those HIPAA compliant vehicles for providing this telemedicine services?
Yeah, so I believe that the reason that they're kind of letting people go hog wild and determining whatever service they have available and using it in unconventional ways is just because they want to try to ramp up people seeing people remotely during this pandemic. So there's less physical touch. And so what actually is happening is that Health and Human Services and the Office of Civil Rights are exercising their discretion to not penalize providers and not enforce HIPAA requirements during the pandemic. But I guarantee you that that will go away once the national health emergency is over. And so in the meantime, and also to kind of to take things a bit further, the examples that they use are FaceTime and Skype and things like that. And the reason that those typically aren't considered HIPAA compliant is because getting a BA agreement is something that's typically not done with that. So, for example, FaceTime, they often say that they're HIPAA compliant, but they will never give you a BA agreement. So it's hard to do that. The VA has argued that FaceTime is HIPAA compliant and they use it, but that typically has to do with some technicalities around how it's used as a conduit and that things are technically not recorded. But in reality, that service goes through a server in Cupertino and then comes back to wherever the other connection is. So there's a potential for privacy issues there. So those types of things are allowed. Things that are not allowed include things like social media, TikTok, Twitter, other social media types of things. Facebook Messenger are typically not considered approved even during the COVID outbreak. So what my recommendation would be is to just use HIPAA compliant software because that's what you're going to be using after the fact anyway. And a lot of that is freely available. Yeah. So for example, Doxy.me is one that's kind of been thrown around all over the place because they're offering free to clinicians to use it for their practices. It's a great way to kind of get into it. It has some limited features, but if you try it for a little bit and you like it, then you can pay for a version with more features. Zoom is also relatively inexpensive for clinic groups. So my recommendation, and I believe the recommendation of the AAN would be to use HIPAA compliant software when you can, but if you're in a pinch, you can use some of these other things, but only during the COVID-19 pandemic.
Okay. Well, Eric, that's all great information, but as with everything else, sometimes things go wrong. I know you practice in Florida and you're licensed. How many states do you practice out of now?
I think it's 30, I think I got my 34th.
30?
So 34 states.
Wow, 34 states. So what happens when something goes wrong? Someone's living in a rural community and they don't have good coverage. Can you hang up and call them and still continue to visit? What do you do when those things come up?
Yeah, so, before this pandemic and before this was became such a widespread thing, we would often, for my clinic patients, I would make sure that wherever they were, if they were going to establish a connection from there, we would test that connection and make sure it worked. So usually staff would arrange for a test connection, make sure they can connect. We usually have them do that when they get home, and then we have them do that about an hour before the consult so that we can make sure that that connection is viable. Now, that being said, if it's not viable, then at least in the old days, we just couldn't do it for the most part, couldn't do a telemedicine encounter. There are situations where the connection is really bad, and it's mostly has to do with the connections on their end. Either they don't have the bandwidth to do it, or they have a carrier that doesn't allow for that service. Then we can switch to a phone conversation as well. Since a lot of those can be time-based codings, you can switch it over to determine which how much of the consult was whichever, and bill from that aspect. But the real issue comes down to the internet traffic, and recognizing that there will be more difficulty with internet connections now. And the reason that is because the internet traffic that we currently use, we share that pipeline with Netflix and Amazon and eBay and YouTube and everything else. And now that everybody's home and using that constantly, and then everybody else is coming home and using telemedicine, everyone's noticing some crawling going on with some of their connections. A lot of the larger telemedicine groups, companies, have either applied for or are already on the GETS network, which is the Government Emergency Telecommunications Service Network, in order to preserve emergency telemedicine services. My suspicion is that after this is all over, what's likely going to happen is there will be a movement to prioritize internet traffic, so that essential telemedicine services will likely be prioritized above, streaming your favorite Netflix show. But right now, that's not the case. So what my recommendation has been to people who are taking up the torch and blazing through with telemedicine services and offering that, is to have a backup connection from a separate provider. So as an example, I have two backups. I do all of my telemedicine through Spectrum, which is my local internet provider, through a business account, and I have a very fast up and down speed to try to preserve that. But if there's ever an issue, because in Florida we certainly have power outages and other things, I have two backups. One of them is a hotspot through Verizon, and the other one's a hotspot through AT&T. And so if I travel a lot, I can always find a connectivity with one of those. And so, and if I find that I'm having difficulty with one connection, I'll just throw the other one on, so that I'm using a different telecom provider to make sure that connection can be preserved. So my best recommendation is to have backups. Excellent. But understand that there will be slowdowns.
Excellent. Well, Eric, this has been great. I really appreciate you taking your time and educating us on this fast-moving, fast-paced industry. I, like you, agree. I think that this is going to just continue to grow, and those who were late adopters will come on board. Do you have any final thoughts that you want to leave with the viewers today about telemedicine?
No, but I guess the only thing that I would say is that having provided telemedicine services for more than half a decade, I would say that it's a great boon to patients to be able to have that kind of convenience, especially neurologic patients who are, for the most part, immobile. With our stroke patients, our dementia patients, our seizure patients, being able to provide telemedicine services for neurology patients is very satisfying.
Excellent. All right. Well, thank you again for being on board with us for this interview, and we look forward to hearing from you later.
Great. Thanks for having me.
Thank you. And thank you for joining us for this edition of the Business of Neurology, and please stay tuned for future episodes.